Welcome back, everybody, for session 3. And the focus on this session 3 is on optimizing safety in PFA technologies. It's about best practices and protocols. This is a presentation session, and it's my greatest pleasure to, of course, welcome back our panelists, Arian Sultan from Cologne, Roland Tilz from Lübeck again. Again, hello, guys. And of course, Vivek from New York. And warmest welcome, Vivek. And it's great you also made it to be part of this very interesting session. And I think I will hand over to you now to present for roughly 10 minutes. And then, of course, we again will have the chance for panel discussion, and the audience can enter any questions within the Q&A, and I will try to bring up and moderate all those comments and questions. So, Vivek.
Thank you so much, Julian. Thanks for having me. Thanks also to the organizers, to Davey and all the other directors. Also, hello to everyone out there. My charge is to discuss optimizing safety in PFA technologies, best practices, and protocols. So let's see here. Okay, these are my disclosures. I have a number of different disclosures, and actually I will be discussing devices that only have regulatory approval today. So if we look at the Manifest 17 case study, where we looked at the safety using the pentaspline PFA catheter, we see a couple of things. Importantly, the overall major complication rate was right around 1%, around 3% minor complication rate. And if we look at the types of complications, and we look at the ones that we're probably most initially concerned about, esophageal complications, PV stenosis, persistent phrenic nerve injury, we didn't see any of that. What we do see, the most common complications are vascular, most of which, of course, are minor, but they're 0.3% major vascular complication rate. I don't think that comes as a surprise. The tamponade rate was fortunately quite low at 0.4%. Stroke occurred in 1 in 1,000 patients, as is TIA, and death was less than 1 in 1,000. The two sort of unusual complications, not terribly, not expected, certainly by me, were coronary spasm and haemolysis-related renal failure. So not just hemolysis, which happens quite frequently, but actually causing renal failure. Notice that both of them, in terms of clinical events, happen quite rarely, around 1 in 1,000 or less, but very important points to consider. Let's talk about spasm. I think one of the things to understand is that there are two types of spasm. There are maybe more, but at least two types, the way I think about this. There's a generalized spasm and a proximity-related spasm. So generalized spasm, the way we define it is ablation anywhere within the left atrium, including the posterior wall, for example, causing sort of a diffuse spasm, like Prinzmetal type spasm. And this, by the way, is not new to electrophysiology. It turns out, and this is a very nice analysis from a multi-center analysis from Japan, looking in over 22,000 patients, 15 hospitals, and spasm occurred in 2 in 1,000 patients. Most commonly, interestingly, with cryoablation, but also occurred with radiofrequency ablation. And this was relieved with nitroglycerin administration. And I should note that this kind of generalized spasm can be quite dramatic. It has been reported to cause cardiac arrest, requiring emergent circulatory support. So this can be pretty impressive. And then there's the proximity-related spasm. How often do these things occur? Well, in the Manifest 17K registry, what we saw was the majority of the spasm was proximity-related spasm, and 3 of the cases were generalized. And just to give you a general idea of what we're talking about, this means with the generalized, we're talking about a rate of 0.02% of the full cohort, which is certainly compares favorably with what's seen with thermal ablation. In these patients, what was EKG changes were seen, as well as hypotension. Not surprisingly, there was a minority of patients that did have severe issues, including 2 patients with ventricular fibrillation, and nitroglycerin was administered in the majority of these instances. So let's talk about how do we think about this sort of proximity-related spasm? And this is from one of the cases where you see a pentaspline catheter at the CT isthmus causing pretty severe spasm. One question is, should we give nitroglycerin prophylactically or expectantly? We know that prophylactic nitroglycerin does work. You have to give significant doses because in order to get a high enough local concentration in the coronary artery, If you're going to give it peripherally, you need to give significant amounts on the milligram level. What's the best dosing strategy? Well, in our experience, we tried a number of different strategies. I've encouraged people to look at our manuscript in JACC EP and come up with a better strategy. And if you come up with one that works, please let me know. But the one that we came up with was to give 3 milligrams of nitroglycerin IV along with some vasopressors, and then a minute later start your ablation. And we can talk more about that. Is it effective? Well, in patients with normal coronaries, it appears to be effective. What about patients with coronary artery disease? The real answer is we just don't know. We just don't have patients. We haven't had enough patients with significant coronary disease at the point of ablation, so we just don't know. And then there's now an emerging issue, which is the issue of late coronary effects, not the acute, calcium-related spasm effect, but late effects that may be proliferative, and we'll talk about that. This is from one of our manuscripts where we looked at ablation, not just of the CT isthmus, but also the mitral isthmus. I think in the interest of time, I'm going to go through this quickly. But the long and short of it is when you are ablating higher up, there's a higher chance of seeing spasm than lower down. I don't think, by the way, it's because the coronary artery is any more resistant lower down. I think it's simply related to the proximity of the ablative field to the coronary. When you're lower down, the reality is it's harder to position the pentaspline catheter. But clearly, spasm can occur anywhere along the left circumflex artery. It's also interesting in patients where we used radiofrequency, where we didn't see spasm. If we cross them over to PFA, we do see spasm. So so the issue of spasm is really whether or not the energy intersects with the coronary artery. Let me just skip through this slide. I apologize for that. Okay, so this is a strategy that we like to use when delivering in a prophylactic fashion. First, we give pressors, phenylephrine, et cetera. Then 3 milligrams directly, typically in the right atrium through the long sheath. Then wait a minute and then start commencing ablation. And then we give additional nitro every 2 minutes thereafter. This is a case report that I think is important. This is using a different focal ablation catheter for a CT isthmus ablation, and this was published just recently. And what was interesting about this, you can see patients, you see some mild ST elevation, they receive some IV nitroglycerin, then there was significant ST elevation 9 minutes later, coronary angiogram, which I'll show you, and the patient also had ventricular fibrillation, ultimately requiring cardioversion, and ultimately the patient did well. But there was basically severe spasm, really occlusive spasm, which is something we don't see very often. What was interesting is here, they actually did OCT, and IVUS, not OCT, but they did IVUS, and what they saw was a significant plaque that's shown here. So this, at least, again, it's a single case report, but suggestive that when you have plaque, the spasm may be particularly profound. I just want to emphasize, by the way, this is not unique to pulse field ablation. In fact, the only clinical case of spasm that I've ever had was actually an RF case, and I'll just show it very quickly. It was a 62-year-old patient, 5 prior ablations, had a mitral breakthrough through a mitral lesion. I went to the coronary sinus, gave 2 lesions, 59 seconds, 40 seconds, and in the 3rd lesion, 7 seconds in, he went into ventricular fibrillation, refractory to multiple external shocks. In fact, we were doing chest compressions when we shot the coronary, and let's see here. Yeah, maybe it'll play. Yeah, and you can see the spasm right here in the left circumflex. And there was no flow initially, actually. We had to do CPR, emergent VV ECMO, defibrillation, and fortunately, ultimately, the patient did well. In fact, I just saw him in the clinic a half an hour ago. So that's just to show you that coronary spasm can occur in anything. Now, let's look at the sort of the late effects. We know from preclinical studies, this is from Cars Nevins about a decade ago. This is from work that we did where after epicardial, actually, no, this is from Ed Gershenfeld's group, where during epicardial pulse field ablation, if you look late after this, you can see some degree of neointimal hyperplasia. And this is from endocardial ablation of the CT isthmus, again in a preclinical study, seeing some degree of neointimal hyperplasia. So when we saw this, we got concerned, and we did a study, we published this earlier this year, where patients who are undergoing ablation, 8 patients with mitral isthmus ablation, 8 with CT isthmus ablation, and 13 others with CT isthmus, but using a focal PFA catheter. In all these patients, they had spasm acutely. We gave nitro, et cetera, a total of 30 patients. Importantly, only one patient had coronary disease in this experience. But what was interesting about the study is then we brought the patients back to look late, whether or not at the area of spasm, we saw any late effects. And using coronary angiography, we didn't see any effects in any of these patients. So the total of 30 patients, again, 0 had coronary effects, coronary artery irregularities. Now, we were planning on doing either IVUS or OCT in these patients if we saw something. Since we didn't see anything, we didn't do IVUS or OCT. So that's what we concluded, 30 patients. But look at this study. This was presented by Mark Tam and his colleagues at the APHRS. This is also a prospective study. This was a prospective study. Patients undergoing pulse field ablation for atrial flutter using the pentaspline catheter. They received intracoronary nitro, though I would argue that the amount they gave was relatively small. But either way, I don't think that matters. What's important is this. They did OCT before ablation, during ablation, and most importantly, 3 months after ablation. And here's what they saw. If you compare the baseline versus a 3-month period, there was a small decrease or a small change in the caliber of the vessel. But most importantly, there was one patient who you see here. This is pre-ablation coronary. This is during spasm. You see some spasm, and that's no big surprise. But 3 months, there was evidence of some mild narrowing here. When they did the OCT, they actually did see neointimal hyperplasia. So I think this is an important point. Is this unique to pulse field ablation? Well, not really. We know from very old data, and this is one study published a little over a decade ago, there's actually even older data that shows in animal studies that after radiofrequency energy, you do see neointimal hyperplasia. It turns out you also see this after cryoablation. Dan Lustgarten published this years ago, almost 20 years ago, actually, in animal studies. So the question really is now, how important is this neointimal hyperplasia? Is this going to be something that's clinically significant? Is it worse, by the way, with pulse field versus radiofrequency or cryo? I think these are all questions that we still need to answer. I think in the remaining time, I probably have taken too much time. I just want to make a couple comments about haemolysis-related renal failure. How do we avoid it? Well, deliver only the necessary lesions. This is clearly a dose-dependent phenomenon. So the more lesions you deliver, the more chance of renal failure and hemolysis. Avoid poor tissue contact. There's no doubt that that can be an important issue. This is a preclinical study that we did where in a beaker, we looked at hemolysis. If you have no contact, you see the increase in hemolysis with the increased number of applications. If you have tissue contact, since part of that electrical field is in the tissue, you get less hemolysis. And the third point, we learned this from Andrea Natali and his colleagues, that if you deliver saline, when you deliver a lot of lesions, then you can mitigate, basically flush through the kidneys, and you don't get the renal failure. You'll still get the hemolysis, of course, and certainly that can be an issue in certain patients, but you won't get the renal failure. I think with that, I had a few other slides, but basically, I think that's not that important. I want to just end with this last slide, which is this one. I think the biggest danger of PFA is that ablation is so easy that there's the problem of potential overablation. I think I certainly have done cases where at the end of the case, I look back and say, oh my gosh, I ablated way too much. And I think that one of the problems is that our trials are currently based only on acute safety and chronic effectiveness. None of them really look at long-term LA function. I think this is something that's going to be important. And I do think that in the future, we need to be thinking about additional works on targeting sources of AF sources, so that instead of doing empiric additional ablation, we could do empiric PVI and then let's say targeted additional ablation. And I'll stop with that. Thank you very much.
Wonderful, Vivek. Thank you very much for this very nice overview of also rare, but also complications which may be related to PFA. So Vivek, are we buying in the end now a risk or not fully understood risk of coronaries for probably a safer risk profile for the also very rare fistulas, or how do you still weigh it after your experience?
Well, I think we're going to see some data hopefully published soon because there was a prospective study looking at nitroglycerin administration pre-PFA in a FDA study. So hopefully we'll see that early next year. But in the absence of that, there have been several experiences published about nitroglycerin prophylaxis preventing spasm. So in my mind, spasm, it's an important issue to know about, and you need to deal with it when you're next to a coronary. My own feeling is I'd rather pre-treat the patient and not worry about it. But at least you need to pay attention and treat after the fact. So I think the spasm issue, frankly, I'm not terribly concerned about as long as you're aware of it and deal with it. I think the long-term issue of late, neointimal proliferation is an important issue. We need to understand that better. There's not been, to my knowledge, a rash of, coronary stenoses that have occurred. So clinically, that's been okay. But I think we don't know what is happening. Is this a tip of an iceberg? Again, I do want to emphasize, we've been doing RF for decades at the coronaries with irrigation, which clearly affects the coronaries. And there are rare case reports of it actually having an impact. So that makes me feel a little bit better, but I think we do need to understand this better.
Yeah, thank you. Arian, any thoughts from your side?
Yeah, thanks first of all, thank you, Vivek, for this great overview as always. I was just wondering, since you said that it's happening with RF as well, but it's potentially more frequent with PFA, do you see a, let's say, benefit of toggling devices that I can use PFA in the area where I'm far away from the coronaries, and in those regions where I get more in close proximity to coronaries that I could switch to, let's say, RF, of thinking it might be a bit more safer than PFA?
Yeah. Again, when it comes to the spasm issue, for me, I don't really look at that as an important issue because I could deal with it in other ways. I think the question is it really true that if we do RF, we'll have less late coronary proliferation? I don't know the answer. That's why I presented the data as it is. Nobody's ever done the OCT study that Mark Tam and his colleagues did with RF or cryo for that matter. So we don't know how much proliferation there may or may not be. So I really think that we need to understand this a little bit better before assuming that switching to RF is better. But having said that, I think we all like to have choices, right? So having the option to toggle is certainly attractive.
No, but my only impression, as I said already, is that people are now more or less reluctant to use energy quite extensively and very close to any other structure outside the pulmonary veins. That's my only concern, that this has been facilitated now with newer technologies as opposed to RF, because with RF it can take some time to create lesions, to create lines, so people are really not being too aggressive from the first procedure, let's say. And with PFA, I do have the impression that a lot of physicians, since it's easy to shoot around, they shoot around.
Yeah.
Yeah, I think Vivek also made this point, not to ablate too much because it was simply feasible. But maybe this is also a good point, moving on with one question for Roland, because Roland, I think you published data on slight increases in the esophagus, also using electroporation. Do you think it is relevant, or do you think it is just a minor observation from your center?
Yeah, I think so. Why did we investigate it? Whenever you deliver a lot of energy, it causes some kind of heating. If the lesions that you create are not based on heating, if you use PFA, RF heating is important to create lesions. For PFA, it's not important. But if you deliver, no matter what energy, in a short period of time, it creates heating. And we know from animals that if you deliver PFA a lot of energy in a very short period of time, you can get even higher esophageal temperature rise. So we wanted to understand what their impact is. And I think what we did find is that there are rare cases of temperature increase in the esophagus. Personally, I do not think that they are clinically relevant. With this technology, if you change the technology, if you change the energy delivery, the energy dose and timing, everything changes. But I think with the bent-up spline catheter, in terms of the esophagus, we are safe. But may I just ask a brief question to Vivek? So I think it was a wonderful presentation as always. And I think we all agree that PFA single shot device is fantastic to isolate the veins. And it's maybe even very safe to ablate the posterior wall. But you also mentioned that we got hemolysis, and there is an impact on intimal hyperplasia. And I completely agree. We do probably have the same effect with RF energy. I also had patients with total occlusion of the circumflex artery when I did an epicardial ablation. So this is also described, and I think there are even case series where after flood ablation, you can see some degree of coronary artery stenosis after flutter ablation. But I think the big issue, the big difference is whether you use a single shot device for flutter ablation or whether you use a focal catheter. And I personally think that we should not use a single shot device where we have a huge right or left atrial area where we deliver the current. It's a large area with a long lesion that we might create in the coronary arteries as compared to a focal catheter. So my feeling, it's not about the energy, it's about the catheter design. What is your impression?
Yes and no. Look, on the one hand, I do agree with you, Roland. I mean, if you're making a line, the line doesn't have to be a mile wide. I certainly agree with that, just from even the atriocontractile perspective. On the other hand, and by the way, the reason we all use the pentaspline catheter is because that's what we had available, right? And nobody wants to open up 2 or 3 catheters because it's economically not feasible. And I think that, so for example, in my own practice, when we're now doing CTI lines with the pentaspline catheter, we actually make it more of a ball, choke up on it to make it a small ball, and then you do the lesions. But I think that the issue of energy really is the issue. I mean, that one case report I showed was actually with a focal PFA catheter, right? So, and what's really interesting, you know, when we did a study that we published, I showed our nitroglycerin strategy. We did it with the focal PFA catheter. And at that time, I thought, okay, with the focal catheter, maybe we won't see as much spasm because it's not as wide of a field. In fact, we actually saw the opposite. We saw, yes, there was not as much of a breadth of spasm, but we actually saw more intense spasm at that location because with the wide catheter, you're actually inefficient because you're not able to get the proper force and get the field as close to the coronary. With the focal catheter, you can deflect it, as we always do, and get it right there at the coronary. So I think that it goes both ways. I don't disagree again with your point. No reason to expose a whole bunch of vessel. I agree with that, okay? But I think the idea that somehow we're safer with focal actually paradoxically may not be true just because you can get more of the field to intersect with the wall of the vessel. You see what I'm saying? At least that's been our experience. And, you know, again, we're all learning. So let's see.
Interesting.
Wonderful. I have one question from the audience, and maybe all of you panelists just briefly comment on this. If in future, even more, not only atrial arrhythmias will be treated, and we are thinking about VT ablation maybe, also going not only endo, but also epicardial, and now having all the discussion about, the corners, but maybe also the phrenic. Do we need to be concerned if we get very, very close from epicardial?
You mean from endocardial lesions getting epicardial field?
Instead of only ablating endocardial, also getting an epicardial approach and be getting very closer. How close would you dare to go from with PFA to a coronary and also the phrenic nerve? I think this is the question from the audience.
Yeah, look,
Vivek, maybe you start.
Yeah, sure. No, look, VT ablation is, I'm pretty sure that we're going to be doing pulse field. I'm not saying it's exclusive, but I know that we're going to be doing, and people are already doing it as it is right now. I think that it's all a proximity issue. There's nothing special about endo or epi. If you're close to the coronary and the field intersects, it's going to cause spasm. So now each catheter has a certain breadth of impact, and we need to learn that for each catheter and waveform. I think the interesting question is going to be, and I'm not worried. I'm worried less about the phrenic. I think that we have a pretty good safety data on. But I'm more concerned about for VT ablation, where ablating a lot of tissue is not just an aesthetic thing, but actually you're decreasing cardiac output. I am much more worried about taking out too much tissue, particularly in non-ischemic patients where your target may be not as big as, you have to go through normal tissue to get to your target. I think that the interesting thing in the future, up till now, it's always been, can you make a bigger lesion to ablate the VT? Soon in the future, I think it's going to be, can you tailor your lesion to really get it to the site that you care about and with minimizing damage to other normal tissue? I'm much more worried about normal myocardium than I am about the other stuff.
Yeah, that's an excellent
I think
point.
this is, Ari, you have 30 seconds here.
Okay, just one quick answer to the question to the proximity of the coronaries. I think reversible PFA, not having used it myself, could be interesting in those cases to see if you're affecting the tachycardia, whatever, but not harming tissue with just the proximity, and have a reversible approach to that. That's just an idea. I never have used that myself.
Yeah, wonderful. I think we need to wrap up now for time reason. And I think it has been a very important and very interesting session. And I'm sure we could keep on discussing all the time. But what I take home, Vivek at least is not worried about coronary vasospasms, but I think a very practical advice is to think about deploying nitro, because this will probably not all, but reduces the chances for vasospasms. And the temperature, according to Roland, also, despite of your publication, you're not afraid for the esophagus ablating with a contemporary device. And we are still learning. It's still an exciting journey. And I thank my great panelists for this beautiful discussion. And I think it's, for me, time to hand over to Devi. And I think Devi will chair the next session. Thank you, ladies and gentlemen. And
Thank you.
see you soon.
Thank you so much.
Bye-bye.